Okay, it looks like it is now the hour. Welcome to everyone, and welcome to everyone who has joined us. You are currently at the third Primary Care Behavioral Health Special Interest Group webinar. We are very excited to have our resident expert, Dr. Jody Palaha, join us today. She is going to be talking about dissemination and implementation science. I will be introducing her in a minute, but first we have a few announcements that we would like to get through. If you are new to the Primary Care Behavioral Health Special Interest Group, we would love to hear from you. And if you would like to join our special interest group, please email Jonathan Novy. You see his email address listed above. And you can also join by going on the CFHA website. The other great thing, as if, we didn't get enough content at our Denver conference. It was really exciting. We have kind of built from the momentum from the conference. We have a webinar coming up in December, in a few weeks actually, related to behavioral health consultation tools for Spanish-speaking populations. This is actually going to be a two-part webinar where we will be discussing not only tools and interventions for use with Spanish-speaking populations, but in part two, we will be talking about the broader context and clinical issues related to this population. So please join us for that. The most important thing coming up is our elections. We will be having a few open slots in our primary care behavioral health leadership special interest group leadership group. So if you are interested, please let us know. Please contact us. We have an opening for co-chair. I am the co-chair this year. I'm sorry, I probably should have said that. This is Clarissa Aguilar, and I am the co-chair for the SIG this year. And then Jonathan Novy is also needing a co-secretary. And there's also another opening for a student representative. So if you are interested, please let us know. All right. I'm about to introduce Dr. Palaha. I don't think there's anything else I need to discuss. So I'd like to welcome our resident expert, Dr. Jody Palaha. She is an associate professor in the Department of Family Medicine at East Tennessee State University. Dr. Palaha's career has centered on integrating behavioral health services into primary care. She has played a role in the development of state policy around integrated practice, and she has an active program of research focused on integrated care, program evaluation, and development. She's very involved in the university's interprofessional education and research program, and she is the current editor of Family Systems and Health, the journal for CFHA, along with Dr. Nadia Centergy. Welcome, Dr. Palaha. We are so happy to have you, and thank you for your time.
Well, that was the best introduction ever. Thank you so much. And let me just transition to my slides. Here they are. So enthusiastic. I hope I can match it. Welcome, everyone. And if you're at the desk right now, I hope that you'll take a moment to stand up and lean to the left and lean to the right. I'm actually at my desk right now. It's that time of day, isn't it? Where no matter where you are and no matter what time it is, wherever you are, it's that time of day, I'm sure, where you need a little stand and you need a little break and a little stretch. So feel free to do that. And we'll get started. I'm actually trying to forward my slides. Here we go. Clarissa did a great job introducing me. I will just say that the PCBH model is near and dear to my heart. This is a picture of me in a rural practice in Nebraska where I first encountered PCBH and practiced PCBH in 1998 and have been doing that work ever since. I am currently at East Tennessee State University, where I've worked in a number of research, clinical, and teaching capacities, and have brought PCBH with me through all of that work over the last over a decade here at ETSU. I want to start by just telling you a quick story, though. When I started in Nebraska doing a model of integrated care in a rural pediatric primary care practice, and I was learning about models of integrated care and kind of having a lot of these early aha moments about the value of being in primary care as a psychologist or behavioral health provider. I noticed that a lot of providers were struggling with specific problems around kind of populations or groups of people within the clinic. And one of those was ADHD. And I got really interested in sort of solving this system-wide problem of ADHD. And I went ahead and evaluated kind of what kind of model were they using for assessing ADHD in the clinic. And this graph shows you the methods they were using to assess ADHD for kids who came in whose parents were concerned about ADHD. This is data we took around the year 2000. They were using some measures called the CLAM, which were sort of quasi-evidence-based measures. They were using a task called the TOVA, which is not an evidence-based measure. They were using a parent and teacher checklist that they made up, so it was definitely not evidence-based. They were collecting IQ and achievement tests and gathering school info, which is certainly a good idea when you do an ADHD assessment. And when you ask the practice, you know, like kind of what do you do to assess for ADHD, they said, these are the things we collect to get a sense of whether or not the diagnosis is appropriate. But when I actually went through a year's worth of charts and looked at, you know, about 100 kids who had come in for an assessment, you can see here they weren't actually collecting these data on even half, really, of all of the patients that came through. And so they sort of thought they had a model. It wasn't really an evidence-based model, and actually they weren't using it consistently. If you think about some of the specific evidence-based measures that we would recommend, such as the BASC or the Connors parent and teacher rating scales, or the ADHD parent and teacher rating scales, which are based on the DSM, or the IBERD Child Behavior Inventory, which is a way of assessing a broad range of externalizing behavior disorders, you'll see that they weren't collecting any evidence-based measures. And this was before the Vanderbilt tool was invented or introduced. Many of you probably are familiar with that innovation in primary care now, but the point is, back then that wasn't an option, and evidence-based practices were not really happening, and even non-evidence-based practices, as I just showed you, were not really happening. And it was an opportunity for me to sit down with the team. This is not our team, we're not that beautiful, and have a conversation about kind of how can we make this better? Who are the stakeholders in the clinic who can help us improve this process? How can we implement an evidence-based model? What would that look like? And I was struck by kind of a new sort of aspect to team-based care. Certainly by this time, I had been impressed by how a team could get together around specific individual clinical problems. So a kid would come in to see me, and it was so easy to collaborate with physicians, nurses, and others who were in the primary care setting. So by that time, team-based care for specific kids that were coming into my clinic was a thing, right? And now, like, I'm realizing, oh, there's actually a pretty interesting, different way to leverage the team, which is to problem solve system-wide changes and implement new processes. And I kind of like had this aha moment about the varying ways in which a team approach could be functional in primary care. And we did, and we implemented a system where we had, really a protocol for the front desk in terms of handing out the appropriate rating scales and scheduling follow-up visits. We had some tools we developed for the primary care providers in helping them make sense of those rating scales and perform an appropriate diagnosis. And then if needed, kind of refer to behavioral health. So it was a very, I know Kirk and Patty would refer to this as kind of like vertical integration, kind of a protocolized approach to handling this one specific and very troublesome chronic problem in primary care. And when we came back 3 years and we pulled all of the charts using the same method for kids who had been evaluated over the last year and even at 3 years after we started the program, what we found was they were following the protocol about 95 to 100% of the cases. Actually had the measures in the charts that we told the practice to collect. So like, you can see the dark blue, there's none, right? That's the baseline data. They weren't collecting any evidence-based treatments. We implemented a program using a team, and this is what we got at 1 year in light blue and at 3 years in green. Some really interesting follow-up data. And I want to just draw your attention to the fact that this does not show that the kids in the practice did better, that they were better managed, that they did better in school, that they had better social skills, they had more friends. It doesn't show any improvement in patients at all. There are no patient outcomes in this study. This is just a study that showed that a primary care practice can implement and sustain an evidence-based approach to assessing ADHD. It was a very exciting project, and yet, the outcomes are ones that aren't typical in our field or aren't the ones we oftentimes think about in our field. And yet, we were able to publish the paper in the Journal of Pediatrics, which is like the premier journal that particularly the clinical pediatricians, not necessarily research pediatricians, but for sure clinical pediatricians read to learn about innovations in the field and figure out how to innovate their own practice. So in spite of the fact that we didn't prove that ADHD got better, right, we were still able to publish that. And I want that story to sort of serve as a platform for our conversation going forward about PCBH research and where it's at and kind of how to think about dissemination and implementation science in that realm. So kind of shifting from a story to a sort of theoretical model for how research happens. This is a picture of the Translational Bridge. I did not make this up. This is a concept that was described by Zerhouni in 2003. I did, however, commission this drawing of a bridge. My dad was an engineer and actually built bridges during his lifetime and happily helped me get an accurate bridge that I could use for this metaphor. So credit to my dad on the drawing. This bridge shows how science has evolved, the architecture of science. And so if you think about the actual structure of the bridge, the things that support it underneath, the pieces that make the connections across the water, the pieces that connect it to the land, those are things like journals and grant mechanisms and the scientific methods that make up science. They kind of provide us with the ability to do science. And if you look at the far left side of the bridge, it's well connected to the land. That is we think of that as the basic science area where we do studies to find out, how things work in a very basic way. where they come from and how phenomena are related. In the middle of the bridge, we study effectiveness or efficacy. We start applying the things from basic science to develop interventions. And that's where you see models like randomized controlled trials or grant mechanisms like the RON mechanism, or some of the top tier journals where we publish the results of clinical trials. That's the bridge that creates the architecture by which science happens. And we start testing out treatments and seeing which treatments work in very rigorous methodological projects. I should say very methodologically rigorous projects. Okay, so what you'll notice is that on the far right, the bridge is not connected to the land. And that is where we take the results of the effectiveness trials and try to take them to the streets, right? So if you could continue the drawing to the right, you would see hospitals and primary care clinics and schools and communities, and you would see the architecture continue in the form of roads and stairways and ramps into the buildings and into the settings where we do this work clinically. And so, the research basically translates the research methods, the research support architecture, the journals, the grant mechanisms go all the way to the finish line. And the fact is they don't. We don't have a fully developed science, and that's why there's a pretty significant gap in the ability for much of our science to make it to the real world. So you've probably heard this by now, but something like it takes 17 years for evidence-based treatments to be implemented in real-world community settings. It's just not translating well. And that's because you kind of have to take the intervention, climb down the bridge, hop in a rowboat, paddle across to the land, right? And many of the interventions that are developed in the middle of the bridge are not sensitive to contingencies in the real world, so they don't translate very well. And people in the real world are not necessarily reaching across the bridge for knowledge about how to do their work. It's pretty inaccessible. It's published in journals. It's published in these clunky scientific papers. And so you have a real problem right there. The field of dissemination and implementation science is trying to develop the architecture on that part of the bridge, the architecture that leads into hospitals and primary care clinics and all of these places, so that there is communication in knowledge and also scientific methods to do things. And let me just be absolutely clear in my language here. The architecture itself, the roadways, the ramps, those are the methods of science, right? So models and frameworks, grants, journals, the kinds of things I've mentioned here. But the findings of science, the findings of studies that use that architecture is what moves around on the bridge, right? So the findings of a randomized controlled trial on, say, 2 different treatments for depression, those findings hopefully move along the bridge, right, into the real world and are translated using more architecture, right, to figure out what works. So D&I science is all about trying to increase the capacity of research to make an impact in the real world. And the other thing I want to point out is that this is not a one-way bridge. So of course it makes sense that basic science would inform efficacy and effectiveness trials that would then inform D&I science to get things transported to real world settings. But it also goes the other way. So to the extent that people in real world settings do good, strong quality improvement initiatives, program evaluation, and even research studies, that information then translates backwards. So people in the middle of the bridge can look to researchers and other contributors on the shore for information about what worked and in the real world, right? and then retool the effectiveness and efficacy studies and try to make sense of, try to evolve interventions that have impact, right? Speaking of impact, it was around 2010 that I first heard Miller and colleagues say this. I actually heard a lecture. They put this on the screen. Impact equals effectiveness times reach. And their argument at that time was that our field, behavioral health in particular, was not having enough impact because we focus too much on learning about whether treatments are effective and not trying to figure out how to get them to people. So it kind of goes back to the bridge. There's been a huge focus on the middle of the bridge, and you can see the architecture is quite well designed, but we haven't quite figured out how to make things, get things implemented or make them reach the far shore. And I was really struck by that. I'll say this too, you know, I finished this pediatric study that I started talking about at the beginning in the early 2000s. And every time I told somebody about this study, I'm talking about this one, right? They were impressed and they were like, that's so super interesting. What was your theory for how that worked or why your practices were able to implement that effectively? And I was like, I don't know. I don't have a theory. We just sat everyone down around the table and we just came up with this idea and we just did this thing. And it was like people had an appetite for implementation studies and implementation outcomes like this, but they didn't really understand. They weren't okay with not having models and frameworks and grants and journals and sort of the architecture to support this type of research. It just felt very much like quality improvement and not really like the way that science advances. And so I was very challenged, even though I enjoyed doing the study, very challenged to figure out how to fit this into the scientific literature, how to explain why it worked, other than because I think we did a good job. Then I, started learning about translational science, and then I saw this impact equals effectiveness times reach, and I was like, oh, this is super interesting. And shortly after that, I heard for the first time of the field called Dissemination and Implementation Science and thought, oh, wow, this might explain some things. And it was in 2013 that I took a sabbatical and actually spent some time learning about the field. It was it was definitely in its early years, probably maybe 5 years old at that point. There were just a few conferences and training experiences around the nation to try to get people to pick up this area. And it was a perfect fit for me because I was already sort of doing it, but not in a way that was super scientific, with super scientific rigor. So that's kind of my story and how I came to D&I science. And what I want to do today is talk briefly about kind of what are some broad areas for input within PCBH using D&I science. And then I'm going to focus on one of the two rather than try to talk about both of those. I'm going to focus on implementation outcomes, give you a definition as well as walk you through a few examples. And then I'll end with a few challenges that I feel like I see in this area. So if you're thinking about like, well, what can D&I science do for me? Because I know you think about that probably pretty much every day, right? It can do two things. One is the models and methods coming out of implementation science can help you articulate the strategy or process that you're using to implement PCBH in your clinics. Ultimately, when you come out with a successful project and you've been running PCBH for 5 years, and you've shown some sustainment, or you're running it in a cost-effective way, or you're running it in a way that shows, decreased provider burnout, whatever, let's say you do a great job. How do you explain to the universe how it is that you implemented PCBH? Because if you don't have a step-by-step process delineated, then how can anyone replicate that or pick up what you did and take it to the next, level? You can't. And we don't encourage you to just sort of list your process out organically, because the literature can't build if everyone just kind of gives a narrative description of their process. It just becomes a lot of narrative data. Oh, well, we started with, this, and then we hired 2 physicians. Like, that's too vague and too scattered and too diffuse to help move science forward. So the field of D&I science has put forward dozens of theoretical frameworks for explaining strategies and processes of implementation. One is the CFHA method that Dan Schroeder and all put out. And I'm not going to talk about this in detail. I'm just going to say that here you can see one model of explaining how it is that you took something and implemented that something, considering all the individuals involved in the inner and outer settings, considering adaptations you had to make to existing interventions or structures, thinking about the processes, the iterative processes that you used. Every model is a little different, and I would encourage you to just look around online and look at implementation frameworks. You can Google it, and you can find lots of good examples. If you're about to implement something, why not follow an existing implementation framework? Then later you can write a paper about your process, and you can talk about how you prospectively used this implementation framework. If you've already implemented something, you've set up PCVH in a practice, maybe look at these frameworks and see if any of them describe, at least loosely, the process that you used. And by all means, if you write this up for a presentation or a publication, hang the method you used on an existing framework so that our field can start using sort of common languages and common signposts for understanding processes for implementation. So that's one way that you can input to the field of PCVH in the world of D&I science. Another one is by studying implementation outcomes. And my example of the ADHD assessment is just that. Consider these 3 boxes. This is from a paper, a very wonderful paper that I constantly refer to by Enola Proctor, where she describes implementation outcomes in great detail. We're not going to talk about all 3 of these boxes. I just want to make the point that historically, research has only focused on client outcomes. How's your patient doing? Are they better? Are they happy? Are they more functional? Are their symptoms gone, etc.? Implementation outcomes are more about the reach of programming, whether they can actually be implemented in the real world. And for so many things, we now already have plenty of studies showing good client outcomes. Think of any evidence-based treatment, and you'll see that we have many expensive randomized controlled trials showing that a body of research supports the use of CBT for depression or the parent-child interaction therapy for behavior problems in young children. We have dozens of these. I would call it an armamentarium of evidence-based treatments, but we don't know how to implement them. And so implementation outcomes are all about how they do when you try to implement them in a real world setting. And there are many people in D&I science who would argue that our science needs to shift heavy to the implementation outcomes side and sort of back off of continuing to prove that treatments work in terms of patient outcomes. Because you can have the most wonderful treatment that works. And I'll give you an example, immunizations. But if no one wants the flu shot for wide-ranging reasons, or they can't get it, or it's too expensive, or they have attitudes and beliefs, etc., that prevent them from getting it, then it doesn't matter. Again, impact is not just about effectiveness, which is the blue box. It's about effectiveness times reach. And reach really is part of it depending on how you interpret the word reach, it's broadly what you see in the green box. So let's talk a bit about what are implementation outcomes. I've already sort of alluded to this. These are indicators of implementation success. They're ways of knowing whether or not the treatment is getting picked up in the real world environment. If you're doing a quality improvement process and nothing more, implementation outcomes are awesome ways to know if you're starting to get the process up and off the ground, or if you're having some challenges. And they can be really helpful indicators in, PDSA cycles or rapid cycle QI, and like going, oh, this isn't working. We haven't actually gotten any, haven't, been reaching the number of people we need to reach, or it's costing too much, et cetera, et cetera. And so implementation outcomes are important across a range of functions in healthcare settings, but I think they represent a key opportunity for any of you out there who are doing PCBH clinical work and want to take a little bit of data. Don't try to design a clinical trial with patient outcomes, client outcomes. It's hard to do. It's resource intensive. You'll have to turn your clinic upside down, randomizing patients to different groups. Forget it. You can get some awesome implementation outcome data through your EHR or through simple data assays. And I'll just talk about a few examples now. So one thing that I really like, one of the interesting implementation outcomes, and actually for these next few examples, I'm leaning heavily on a paper that I don't cite here, which is not recommended. I recommend citing your sources. This is a paper by Hunter is the first author. Funderburk is the second author. I'm in there somewhere. There's probably 6 or 7 authors on the paper. It was published in the Journal of Clinical Psychology in Medical Settings or something like that. And it's a special issue in 2018 that focused on PCBH. And you probably all have seen that issue because it's been, highlighted quite a bit within the community of PCBHers and even outside of that community. This paper in particular is one that sort of reported on the state of research within PCBH, and there's a section on implementation science. I wonder how that got in there. Just a little sarcasm. What I've done here is just extracted the implementation outcomes from that paper, just so you can see some examples. So acceptability is stakeholders reports whether the PCBH model is agreeable, palatable, or satisfactory based on their direct experience with it. It's more than just a satisfaction survey, and it should be quite targeted and ask about very specific components of the model. What we know right now, there are, I don't know, 6 studies out there that have sort of acceptability-ish data in them. So, for example, if you look at that second bullet, there's a study by Jen Funderburk in which people appreciated or rated highly the component of the model in which the BHC was highly accessible. And of course, that's a key piece of PCBH. So knowing that they enjoyed that, they found that acceptable is really important. How do you measure acceptability? Usually through self-report. And Bruce Weiner has this great, fairly recent paper where he did the validation of this particular acceptability measure. And what I would recommend for PCBHers is that you use these questions, but you insert not PCBH meets my approval. That's not helpful. But more the specific components of PCBH that you're implementing. So finding a behavioral health consultant at the point of care for a warm handoff meets my approval would be the way I would word that. And you ask it about you ask it all 4 ways. It's appealing to you, I like it, and I welcome it. Then you might ask about another component, interrupting the behavioral health provider when they're in the middle of a session with another patient. Meets my approval, is appealing to me, et cetera, et cetera. No one's done that yet. And I think it's a really important study. I think getting some feedback on all the components of PCBH that we all think are really active ingredients would be helpful, but not from people who are oblivious, right? Again, this is from people who have direct experience with the intervention. Okay. We also have some studies on this implementation outcome known as adoption, which refers to the PCP's intent to engage the PCBH model services as prescribed. This is kind of like uptake. And it's not just the adoption by the PCP, it can also be adoption of certain practices by the BHCs. So, and this is like an especially interesting question. If you try to retrain a bunch of behavioral health providers that never did PCBH, and now like, are they doing it? I just heard today that one of our providers, books 5 follow-ups in an afternoon. That's not adopting the model, right? So, studies of adoption are looking at, people's follow-up or uptake. You can do that through self-report. That's okay. And if you look at Proctor's paper, she'll give you some options on how to measure all of these in different ways. We have a few examples in the literature already. Again, you can kind of look at that Hunter article to kind of read up on sort of what do we have in the area of adoption. I'm going to give you just a quick example. I'm sorry, I'm skipping across a couple of these just so I don't run out of time. Here's an example. I implemented PCBH in 2014 at a pediatric primary care clinic, and of 419 kids who were coming in for a 4 to 5-year-old well visit, 86 of those kids scored high on a screener for behavior problems. So 20.5% of 4 to 5-year-old well visits were significant for behavior problems. And what you see on the right there is that of those 86, 50 were referred by their primary care provider to the VHC for a warm handoff. Then in 2015, in addition to regular old PCBH, we also advertised an evidence-based treatment called the Family Checkup for these kids, specifically 4 to 5-year-olds with behavior problems. And as a result of that effort, what you can see is that we increased our adoption of the warm handoff for behavior problems by quite a bit, went up to 80% clinically or statistically significant increase. That also comes from a paper we published in the Journal of Family Systems and Health with J.D. Smith as the key author and myself as a co-author. I really need to write my references on these slides, and I apologize. Another important implementation outcome is cost, and that can have huge implications for whether or not an intervention actually happens in the real world. And cost can be evaluated in a wide range of ways. I'm not going to get into all of that, but you're familiar with some examples, and these are 2 PCBH studies that are already out there that looked at cost. One is decreased hospitalizations, so cost savings. And then the study I did with my dissertation student, Natasha Guj, where we showed that providers who had the PCBH model in place saved time and were able to bill more visits, generating more revenue. So those are some examples of cost as implementation. I'm going to skip fidelity because I'm going to come back to this one at the end and just talk about penetration briefly. This is the extent to which the PCBH model reaches the people that it intends to reach. And I think this is one of the most interesting and provocative implementation outcomes for PCBHers. Because I think an unstated key what am I trying to say? Sorry. I think an unstated but key component or attribute of PCVH is access, improving access. That the warm handoffs and the kind of integrated milieu and the sharing of space and all of the education and staying accessible and not, scheduling lots of follow-ups, et cetera, is all kind of geared to being accessible. And the only way to know that is to know how many people we get to. But the problem is a lot of people who do very basic evaluation studies of these kinds of efforts study what I just said, which is the number of people. And the number of people that you touch through a PCVH service is not a very helpful statistic because we don't know how many you could have touched, right? It's all relative, which is why I love the measure penetration because it gets at the percent of people that you're reaching. We haven't seen much work at all in this area. The paper I referred to earlier, which is not Palaha et al., but Smith, Palaha et al., in which I showed you the adoption rates, that also had some penetration data. You'll notice that if you're on the CFHA listserv, Drs. Bowman and Beachy frequently publish their penetration rate, which is the total number of patients their service has seen in a given period of time, divided by the total number of visits that the practice had. And they oftentimes see penetration rates of 20 to 25 or even 26 or 27%. That means a behavioral health provider is engaging with a quarter of their population. It's a very impressive penetration rate and I think an important implementation outcome for all of us to kind of have on our dashboards as we go forward. Oh, look, I do have data in here. I had no idea. I'm not going to talk about this data because it's super complicated. I want to instead jump to 3 key challenges. Penetration rates are not complicated, but that chart is complicated. At least it is if I try to do it really fast. So let's talk about these 3 key challenges that I see as critical areas for the field. One is this interesting challenge of developing the science of PCVH from the endpoint. And I'm going to bring up this bridge again. The endpoint is off to the right here. It's not in the picture. I should have had my dad draw a little town there or something. A lot of times, as sort of how I described things earlier, we get treatments developed in the middle of the bridge, and they're based on basic science and applied science, and they're pretty well thought out. And the studies that are done are quite rigorous. And then those get passed to us at the endpoint. And what I was saying earlier is that oftentimes they're very clunky and don't fit well in real world environments. But still, there's a wealth of literature and empiricism around those models. What's happened with PCVH is that it didn't start on the bridge. It started in the real world. And that isn't to say there hasn't been some good research all along, and that isn't to say there aren't studies unrelated or non-specific to PCVH that don't support the model, but really PCVH was a clinician innovator-driven movement in the real world in response to a demand for improved primary care and an opportunity by people who are experts in behavior change to jump in there and be helpful. Behavior change, among other things. And so we're trying to build it in the village off to the right and then sort of push it back over the bridge, right? And the problem with that, I'll give you an example. If you apply to an NIH grant mechanism like an R01, which is a piece of the architecture right in the middle of that bridge, they're going to ask you what your theoretical model is. They're going to want to see the literature behind PCVH. Those grants don't fund, I'll just say, quote, harebrained ideas. And I don't mean that PCVH is a harebrained idea, but the only way the science knows how to evaluate whether something is legit or not is by its history with science. And PCBH doesn't have a history with science. It has a history with within clinical innovation and clinical circles. And the science is coming, the architecture is kind of being developed in the opposite direction as the way that it normally is. And again, I said earlier that the bridge flows two ways, but ideally you would have work being done in both places. And we need to see that happen. It's just a challenge in terms of how do we get some of these bigger studies funded when we don't have a history with working in that zone. The other big challenge to PCBH right now is that we lack a really clear fidelity model. And not only that, but a fidelity model for PCBH could be quite complex. When I say a fidelity model, what I'm talking about is a detailed recipe. If you tell me that you used PCBH in this research study, how do I know you did? And what do you mean by PCBH? Because science leans very heavily on replication, and we can't replicate things for which we don't have clear operationalized descriptions. So a fidelity model is the recipe for PCBH, and no one has given us a very operationalized definition. I think the closest thing we've got so far right now is kind of the GATHER acronym, which I love, and I think it's a great starting point. But, practice as a generalist doesn't really operationalize what that means. And if I say we were practicing as a generalist, it might mean something quite different than what you might do if you tried to do that or replicate that. So this is a problem the field is working on right now. In fact, some of my colleagues and I are working on it. One of the other great tools we have out there right now is a tool called the PPAQ, which is a self-report model for gauging fidelity to the model. And you can find that in that Hunter paper as well, a reference to the PPAQ. Its first author is Beeler. But this is also quite a complex problem to work out. If you look at this picture, what you'll see is there's some medicine in that bottle. And the medicine in this metaphor is representative of an evidence-based treatment like, let's say, focused acceptance and commitment therapy. Maybe that's your intervention. And focused acceptance and commitment therapy can be quite effective. Maybe it's MI, maybe it's CBT for depression. There's all kinds of different medicines that we deliver in PCBH. We deliver them through this needle or syringe, and the syringe and needle are kind of the structure by which those evidence-based treatments are delivered. And so the needle and syringe in this picture up on the far right there is PCBH. And how it's structured is 4 sessions, and there's 4 handoffs, and it's brief sessions, and it's decibel, and it's generalist, and it's education, etc. That's the structure by which these interventions are delivered. But there's another level, which is who's holding the syringe and the medicine in their hands. That's the context in which all of those things are unfolding. So, we're using these interventions vis-a-vis PCBH in, like for me, it's in a residency training clinic, but for you it might not be, or in a place where we have really engaged physicians who all attended CFHA last year and are super on board with our model, versus in a setting where there are limited resources and your primary care providers / nursing staff are not as well versed on this particular model or understanding what it is. And so there's all these contextual factors that are relevant to how it's implemented. And when you describe what you did, you really have to describe like all 3 of these domains in order for someone to fully understand what you did to get the outcomes that you got. Okay, and then the last challenge is that there are few studies of adaptive treatment. So coming back to this picture, the medicine in the jar, like we don't have a lot of studies on 1 session interventions. We know that CBT for depression can be really effective, but most of the randomized controlled trials are 36 session interventions or 13 session interventions, and you're just pulling out a few core components and implementing them in 20 minutes. And does that work? There's a science to adaptation, and as we explore the potency of these various interventions used in these brief formats, we really need to be aware of whether or not what we're even delivering through CBH is evidence-based in and of itself. And I hate to like toot my own horn, but there was a great, this isn't even really me so much, I was just quoted briefly in this article that appeared in the Atlantic in August. They did a piece on single session interventions. So if you have a minute to Google the Atlantic, one session interventions or single session interventions, it should come up for you. That writer is amazing, and she did a really nice job describing the literature that's out there on brief interventions. There's actually a link in that article to another article she wrote that I actually was more a part of, which does a nice job of explaining PCBH to a layperson, if that's a helpful resource for you. That other article appeared in 2017. So I just want to also can never turn down the opportunity to say that Dr. Sinderji and I have been editing this journal for almost a year. It is a journal that is very much interested in integrated care and innovation in the delivery of healthcare, particularly as it relates to families, particularly as it relates to systems of care. And we are especially interested in rigorous program evaluation and endpoint research, people who are trying to study implementation outcomes or use implementation frameworks to explain their models in real world practice. So I hope you'll read some of the things we've written and certainly consider submitting your own work if you're doing some. I did put at the end of the slide deck a bunch of things I've written that I think are good summaries of much more complex literature in the D&I science realm. There's a slide here that shows 2 chapters that I've produced that kind of summarize D&I science and opportunities for behavioral health consultants in primary care settings. And then I also want to draw your attention to these editorials, which all kind of deal with different implementation outcomes and sort of parse out some of the key issues. In December, for example, that one at the very top will talk about evaluating time in healthcare and how do you study how much time someone spends. I think time is a critical variable in terms of an implementation outcome that's relevant for PCBH. Okay, I didn't do what a lot of people do and put a bunch of contact information at the end, but I'm happy to have anyone reach out. And I know I finished a little early. I guess we could take questions. I love to do that if it's feasible.
Oh, hold on. All right. So thank you so much, Dr. Palaha, for that wonderful presentation. We can keep our eye on the chat box if people are interested in asking some questions. Let's see here. I was really struck by how reachable everything always seems when I hear you present, Dr. Palaha. It's always like, oh yes, I could do that. So I really appreciate.
It was that easy, right?
Yes, I can really appreciate that. It always seems so doable, although it's not. I guess it's not always so easy. So let me see here if we've got any questions coming in.
Just while we're waiting for, while we're waiting for questions, if anybody has any questions that they want to put into the chat box, I'll just say, like, we try really hard to incorporate D&I training into our annual conference every year. We have a research and evaluation training track, and usually at least one or two of the sessions are implementation science focused, and that's another place where you can get some training in this area. If you're really hardcore and you want to do like the tighter experience that I was talking about, there's actually a few of us in CFHA that have done it. Dr. Funderburg did it. Dr. Shepherdson has done it. Dr. Tina Stutz, who has been a member of CFHA for a long time, has completed it. I'm happy to follow up with people and give you some tips on how to do that. Here's a question. What advice do you have to make incorporating the BHCs into provider workflow more accepted by the providers? It's a great question. It's actually an implementation question. And so, and a question about the recording, and I would assume so. We have been recording since the beginning. So Maria, I hope you'll have a chance to catch the beginning if you didn't hear it. I know that a variety of strategies, well, let me just talk about scrubbing. So I've heard a lot about strategies involving scrubbing the schedule, where BHCs pull the schedule before the day starts and kind of look through who's coming in, and during a morning huddle, or like in our local pediatrics practice, they don't do a huddle. So our BHC just kind of makes the rounds before clinic starts and says like, hey, I notice you have these 2 or 3 patients coming in, Mr. So-and-so, so-and-so, and these are people that I think would be, great for me being around and being available. Germane to this talk, like, does that work? And does it increase referrals? That's a great research question. No one studied that. I've heard about scrubbing in a variety of presentations now. I've not seen any data on it. I'm actually helping our clinic pharmacist develop a scrubbing study, because he uses scrubbing to help providers identify patients that are relevant for pharmacy service. But again, like, there's no data on that. Now, you may say, well, I asked if it's more accepted by the providers. And there's a couple of ways you can study that. One is you can study, do they make those referrals? Do they engage the BHC with patients who are identified in the scrubbing process? Well, ultimately, actually making those referrals, adoption of that model is almost kind of more important than whether they like theoretically accept it or believe in it or like it, right? But you could also use that measure I was talking about earlier, about whether it's acceptable, and ask later, is it a practice that you like? That the BHC approaches you and says, here's your patients for today. These 3 patients are relevant to me. Here are some things I think I can do that are helpful. And asking if that increases acceptability.
Thank you. That's a great response. And I love that notion. Adoption is actually, in some ways, more important than acceptance. That's interesting, the way to think about it. So we are out of time, but I just want to thank once again Dr. Polaha so much for all of your wonderful wisdom and for sharing and disseminating all of this to all of us. We really appreciate it. Thank you to everyone. Please tune in next month for our next webinar. Everybody have a great afternoon, and thank you very much.
Thank you. It was super fun.